oh, thank you for the recording. Sorry. All right, we missed a little bit on the recording now. So we'll start here with this question for Karen of how do you convince people who are terminally ill that hospice isn't giving up? And why do people always say hospice is where you go to die?
Well, and because, first of all, patients do die in hospice. The vast majority of hospice patients, of course, die. It's rare for someone to get off of hospice. So people have associated with that, especially if they've heard about someone in their community who was in hospice, who died, and they don't quite understand what happens there. And again, it's just part of our phobia around death and dying. But I think the best tool we have to offer right now is palliative care, because palliative care offers similar team approach, team-based care to patients, but it can be offered alongside curative treatment, so patients don't have to leave treatment. And that's one of the biggest obstacles for hospice, is that patients have to decide they're done with treatment in order to go on hospice. That's a huge shift in their mindset and their mentality. And it's too big for some patients to get there very quickly. That's why they wait till the very last days of life. But if they're on palliative care already and they get used to this idea of having a team that's talking to them regularly about meaning in life and helping with their symptoms and helping them navigate both curative treatment, but also looking at other factors on the spectrum of hope, they can gradually move them closer to hospice and tell them about hospice, talk about what it is and what it does. But I still think it's the fact that the hospice payment system requires patients to give up treatment that makes it really impossible for some people to go there, because they're not ready for that step yet.
I want to go back to Craig, and I'm sorry I have to do this, but since we missed him on the recording, Craig, I'm going to ask you another question because it has to be on the recording for the CE quiz. So the question will be very simple. Like, here's the question: is spiritual bypassing considered a diagnosis, and will it ever be in the DSM?
Not a diagnosis, nor do I anticipate that it ever will be. It's much more of a coping strategy than a disorder. Yeah.
Okay, that's just needed to get that in there. Thank you. Okay, other questions? So Brian, here's something for you in your field of expertise. A good friend of mine is a pastor in a very conservative church. And since COVID, what her church always does is they have very elaborate funerals that last hours, like all day, like an 8-hour funeral. And since COVID, they weren't able to do that. And she is noticing now that the people in her church are beginning to show symptoms of complicated grief because they weren't able to do their traditional rituals. So, what is that like in a conservative church? How do you justify that? Or what kind of toxicity could come out for some, would somebody actually say, well, he's not really going to go to heaven because you didn't, do the right kind of funeral? Is that a problem for conservative Christians not doing the
there's no after the person's died any type of ritual that has to be done that guarantees that they're going to go to heaven. So it's not that. It would just be the lack of being able to have what we call a homecoming service. So just that lack of that closure or that celebration, but no concern about the person's soul because you weren't able to have it. But speaking of that, though, there's several churches that even said I don't want you to wear a mask to our church because you're not showing faith. So if you're going to wear a mask, don't even bother coming on our campus. So that some people will take it to that extreme. Yeah, that's been a real problem though, not being able to have funerals and those rituals. And you know how important those closing rituals are.
Yeah. There was in a class that I teach, I use this, I show all these videos of different grief rituals from different cultures. I've got about 20 different ones. And one is a video of a pastor talking about appropriate Christian grief. And what that means is because of the writings of Paul, because Paul said we should not grieve as others do, because we know our souls are going to go to heaven. There are, churches that actually demean people for showing grief and pain, because you're not supposed to grieve if you have faith in an afterlife of reward.
Yeah, and that's the problem with taking those verses literally, because Paul does say that. He says we do not grieve as unbelievers do because we have hope. But he doesn't say we don't grieve. He says we don't grieve as unbelievers do. So I think it can soften it. But again, there are people that take that to an extreme and say I should show faith. I should show that I know my loved one's in a good place, so they won't go through the grief process. And I've seen this cause friction in couples, where one person's expressing the grief and they're expressing their anger and they're having a normal, healthy grieving process, and the other person is just quoting scripture. Literally, I've gone through a couple, and the other person's just, and then the anger from the person who's saying, I can't get any real emotions out of you. So that can be a complicating factor.
Good one. And another thing too, I'm going to just throw in here about grief is, for a long time, people thought that styles of grieving are gender specific. Women are emotional and they cry. Men don't cry. Men go, build a boat in the garage or something. And we now, the research now shows that this is grieving styles, instrumental versus intuitive. So intuitive grieving is somebody, doesn't matter the gender, that's more emotional, that reaches out, that communicates and asks for help and talks about their feelings and cries. And an instrumental griever is one that processes more in a practical way, that will clean the house or build a boat or start a foundation. I'm an instrumental griever. So between couples, that's often an issue in grieving is, you'll expect them to behave gender accordingly, which is not even a thing. And so here's a question for anybody who wants to take it. SBNR, spiritual but not religious, it seems offensive because it's comparable to something like light-skinned but not white, or assertive but not male, in that it assumes a norm based on biased and outmoded thinking. That's for anybody who wants to try it. I'm not quite sure. I don't really see it that way.
Just as to me, this term spiritual and not religious, it's overused. In fact, I hear a lot of Christians using it. They say, I don't have a religion, I have a relationship. So it's become, in my opinion, a little bit kind of overused. But to me, we talked about before, religion kind of is a specific way of looking at things. It's a specific way of rituals, of ceremonies, of beliefs. And someone who's spiritual but not religious is just saying, I don't have anything specific that I adhere to. So it's more of a maybe a smorgasbord. Which again, when I was in Sunday school, they told us you can't do this, right? You've got to be, you're either Christian or you're Buddhist. You can't be both. You can't study, both of them. And people that are spiritual but not religious are saying, don't put me in a box. I do believe that we're eternal souls, but I don't have to describe any specific way of going about doing that.
Yeah, I think I understand what Michael's saying in this question is that it sets up religious as the norm. We're something else, but not the norm. Right. So and you're right. But you know what? Religious is the norm.
It is the norm. Yeah.
Yeah. Whether we like that or not, it's changing. It's not like it was in 1955, but it's still the norm and it's still mainstream. So I guess we just have to compare it against that. And, the thing when we're talking about any of this is language and semantics is always problematic. I don't know who coined that term, spiritual but not religious, but I haven't been able to think of a better one. So if anybody has a better phrase, it's very hard. It's hard for me because when I tell people I'm a chaplain, they immediately have an image of Father Mulcahy from MASH. That's what a chaplain looks like, right? And it actually stresses me out quite a bit because I want to say I am a spiritual but not religious chaplain or a non-religious chaplain. I don't want to introduce myself as a chaplain to everybody I meet because I want them to know that I don't identify with a particular religion. I don't want to scare them away and how do you say that?
Well, and for me, when I was coming out of Christianity, for a long time, I would say I was a Christian, but it was always, I'm a Christian, and then Christian, and I don't believe this, and I don't believe that. And then finally I was like, okay, this is getting too complicated. So I'm just going to stop saying that I'm a Christian anymore. And I think that's what happens with people that say they're spiritual, but not religious. It's like, as soon as you say you're religious, people put you in a box, and they're
Right.
just saying, I don't want to be put in that box.
Yeah. And interfaith and interspiritual doesn't really work either, because that excludes people who are atheists and are not spiritual, are not interested in faith either. So I have a good friend who's a rabbi who calls herself an atheist rabbi because she's an atheist, because she doesn't believe in that God. But she likes the traditions and the history and the culture. So it's very hard. And we struggle with this with chaplaincy. Like Rick is saying, how about spiritual care advisor? That's a lot of syllables to say. Hello, I'm the spiritual care advisor. I'm here to visit with you today. I mean, we really are struggling with the terminology for that. I wish that we could all call ourselves counselors, but there are licensing and legal parameters that prevent us from doing that.
One thing, if I could add, Terri, to
Yes.
just in terms of how to, so when we're working with people and they describe themselves as spiritual but not religious, we really want to listen to their tone of voice, because if someone says, well, I'm spiritual but I'm not religious, my automatic response is, oh, tell me about that. Tell me what that means for you, because I want to know how they define that. But sometimes you will hear people say, and listen closely, folks, well, I'm spiritual but I'm not religious. Well, there's some hurt there, right? There's some reason that they're really wanting to define themselves as not religious, and they're anti-religious. They've had some hurt somewhere. And so that's worth exploring too, because there's a reason why that tone of voice comes up. I mean, there's actually, people will say that with anger sometimes. And we definitely want to explore that with folks, because that has important meaning.
That's a really good point. And what I have found, I'm involved now in, I work closely with a lot of atheist podcasts and atheist groups. And I find so much throwing the baby out with the bathwater with that, and so much orthodoxy, that atheism has a purity test, just like some faiths do. If you don't believe exactly this, then you're not in our group. And I hear so much anger when I hear people talking about that. Like, we don't believe in an afterlife. There's nothing but the physical world. If it can't be proven with science, it doesn't exist. And I see that what you're saying, I see a lot. And it's sad because they have been wounded by religion. Okay, let's see. And this is a question I want to ask too, is in our work, social worker, hospice, doctor, whatever we're doing, would we all agree that knowing a client's spiritual perspective is important? Does anybody not agree with that? That we can provide care without knowing that, no matter what we're doing? Not just end of life, but even if you're a marriage counselor or a school counselor helping a troubled teenager, or anybody in a helping profession, does it seem like it's important to know the spiritual background or perspective of a person?
I would say yes, as a medical doctor, because the spiritual background could inform their perspective on everything, how they see their health or their illness and what they expect from it. And it kind of tells you the frame of reference they're using to look at the world. So I feel like that's really essential to know, in terms of if you're helping them navigate like choices they're going to be making. Their spirituality and spiritual focus is really important.
Yeah, and you could probably speak to this, Craig. In psychology, it really hasn't been included traditionally, has it? There seems to be this big split between spiritual care and psychology.
I think the bridge is being built, but I don't think it goes all the way across the gap yet. So because what you have is people come to the table with their own biases, right? There are people who believe they should be separated. I mean, it's the Freud-Jung split right there, right? Like Freud thought it was horrible and terrible, and Jung thought it was how people made meaning out of life. And we're still there in some respects. I will say though, to the question of, is it important? Like what I do with clients, my intake asks about various identities, race, ethnicity, gender, religion, spirituality, and how salient they are to people. And do they want to talk about it? Do they see that as being important to the conversation? And so I ask two questions around religion and spirituality. How important is it? That's a scaled question. And then, is it something you want to talk about in our work together? And if people say no, I respect that. But some people will say it's very important, but they don't want to talk about it, which is interesting, right? It's a very important part of their identity, but they don't want to talk about it. I don't talk about it at first, but sometimes we build a relationship and I ask if it's okay to ask about that, because I'm curious about when people would say it's a very salient, very important part of their identity, but they don't want to bring it into the counseling process. That's curious to me. So listening to what the client wants around that is really important.
That's a really good point. And, you know, another thing, that we know is that the training in those two areas doesn't traditionally cross over. So your, traditional clergy doesn't get a lot of training in psychology, and traditional, I don't know if traditional is the word, classical psychologists don't get a lot of training in religious studies or spirituality. So we really have these two very separate groups. And Craig, are you familiar with David Lukoff? Do you know who he is?
Know the name, yes.
He's going to be one of the speakers at our conference in July. He and another colleague wrote the diagnostic criteria for the DSM-4 called spiritual or religious problem. And that is actually considered a diagnosable disorder. And their rationale for that is that it needs to be considered in the same way that, as you said, that, race, ethnicity, background, physical health, all these different things, cultural affiliations have to be put into the mix with an assessment. And if you don't put this into it, you're missing a major piece of it. And so they actually got that put in to the DSM.
Yeah, which is huge. And
is huge.
Absolutely. And thanks for connecting me why I knew the name. The problem is it's diagnosed as what's called a V code, which is typically not reimbursable by insurance. So it doesn't help people get paid for services if that is what they're struggling with. But it is still important. It's monumental that it got in the DSM. Absolutely.
Yeah, it really is monumental. And it addresses this whole thing about how those two disciplines really need to cross over.
Mm-hmm.
And I'm going to answer Angela's question about, does the term chaplain push people away? Yeah, it does. But not all people, right? So I have, tried a few strategies. When I worked in a hospital, I would say, hello, I'm Terri, I'm the chaplain. I'm here to visit with you and see how you're feeling. And they'd say, oh, no, thanks. I don't believe in God. And I would say, oh, good. I don't believe in that God either. And that would always just open the door to conversation. But there's another issue with this too. So another friend of mine who's a chaplain at the hospice where I work is a rabbi, and she wears a yarmulke. So she very clearly identifies as a rabbi when she goes to see patients. She calls herself Rabbi Sarah. We have Muslim chaplains, women who wear face coverings and head coverings. Certainly Catholic priests wear robes. Buddhists, chaplains wear robes. So if we are trying to be spiritually inclusive or spiritually neutral, should we dress that way? Should we not wear our religious symbols when we're working with patients? Thoughts, anybody? It's a tough one.
I know a Buddhist nun who was a hospice chaplain who renounced her vows. She returned her vows, I guess, in Buddhism because she felt that dressing in the robes was off-putting to so many patients and she wasn't able to really serve them well. And she just decided that it was worth it to her to give up the robes in order to truly be there as a more neutral chaplain. So she definitely ran into obstacles.
That's a serious commitment. And Rabbi Sarah says, I think it's important for me to represent women rabbis and, to stand for what I've accomplished as a woman in a traditionally sexist religion. So she's, for her, that's like a personal statement. And of course, you would never ask a Muslim woman not to wear a head covering. You would just never ask them to do that. So I know a lot of female Muslim chaplains. I work with them a lot at school where I teach, and they're some of the best chaplains I've ever seen. And they are, so skilled at presenting themselves to patients in an inviting, safe, friendly way. One of them tells a very funny story. She walked into a hospital room and the patient was watching TV and had Fox News on. And Fox News was talking about Muslim terrorist attacks and something like that, just as she walked into the room. And she walks into the room and she stands there for a minute looking at the TV. And she said, "Here I am, a real Muslim right in front of you. Do you have any questions?" So yeah, the way you present yourself can be done, with humor and inviting. And Angela, I think I like the term spiritual counselor too, but I think there are, legal issues around calling yourself a counselor. In some states, you can't call yourself a counselor unless you have a particular license. So that doesn't work for everybody. Let's see what else we've got here. Anything else? Anybody want to do the raise hand thing? Okay, Sarah says, "I'm rabbi to Jewish patients and chaplain to." So how do you introduce yourself, Sarah? Do you wear a yarmulke?
No, I don't wear a yarmulke. I make a spiritual assessment of what would be best. So I will either say I'm the chaplain, I'm from spiritual care, or if I know they're Jewish, I'll often say I'm the rabbi. I'm the solo chaplain of the hospital.
So you can literally wear different hats for different people,
Yes.
so to speak. Another good question. Do spiritual care providers have to be identified with any religion at all? There's a big controversy right now in the military about, can military chaplains be atheist? And as you may have heard, Harvard just appointed its first, he's not the first atheist chaplain, but he's the head of the atheist, of the whole chaplaincy program at Harvard University. And he's an identified atheist. And there are some excellent NPR stories with two different military chaplains who are out and identified atheists who've been trying to have, I don't exactly know what the thing is, but to have atheism classified as an official belief system in the military or something. And they keep losing this fight, but they are still still allowed to be military chaplains. And I think that's important because there's a lot, there are atheists in foxholes, contrary to the belief. Okay, so it looks like we're having a long conversation about chaplaincy, which is fine. We have how many? So we got a lot of chaplains in the audience, some nurses, some social workers. Let me ask all of you, audience, a question. If you're a hospice worker and you do an initial assessment on a family, what do you do when the patient is resistant, but the family is open, and you're having a conversation with all of them, and the family called you in, and the patient is, I don't want to die. You're sending me away to kill me. And the family is, Mom, this is different kind of care. How would you handle a situation like that if you were in the middle of it? Any of you chaplains? Timothy says, move the conversation. Is that what you're saying? Open your mic and tell us about it.
I would invite the family to join me and have a conversation about their context, and then and ask if this is, this might have been a problem in the past in the family. There might be there might be a spiritual pain that hasn't been addressed or hasn't been met yet, and then come back to with the patient. But I think not always does a conversation have to be all together. I think we need to address separate things sometimes.
Mhm.
I'm a social worker.
Mhm. So you're present in the initial intake meetings.
Often, yes.
Yeah. Kathleen, your hand is up.
Hi, I'm a writer, and I wrote a book about my family's experience with hospice. And when I go out to do book talks, I'm often shocked by how much misunderstanding there is about hospice. The usual thing, my mom went into hospice and she died. One woman piped up and said, my mom went into hospice and they didn't feed her.
Mm.
And most often what I find is they went into hospice and their loved one died the next day or in 2 days. They went in too late. And actually my flyer to advertise my talk says, why didn't we call hospice sooner? So how can you professionals that are working with patients talk to them about going in sooner rather than later?
Well, and there's always conflicts in families. I mean, sometimes the family wants hospice and the patient doesn't. Sometimes the patient wants hospice and the family doesn't. I mean, this is part of our, job with end of life, is to be able to be in the middle of those conversations and facilitate it in some way. Not all of us have to do that, but probably most of us do. Stephanie, go ahead.
Thanks. I often talk about hospice as like an untapped benefit to improve the quality of life of patients. So it's so focused on death, but a lot of times if we talk about with whatever time you have left, if you graduate from it or not, there's a lot of things we can do to improve the quality of life and what are those goals of living. So that was just something I wanted to add.
Okay, good stuff.
Yeah, I think that's great because hospice does provide a lot of benefits. It's unlike any other medical entity that we have in terms of what it will offer to patients. So I think sometimes, just talking about the fact that your medications will be covered, durable medical equipment is covered, we provide a home health aide and a volunteer. I think that focusing on what hospice offers is sometimes the best way, as you're saying, to convince people that it's worthwhile.
Well, we have a long way to go. It's fortunately, we've got good media on our side right now. There are lots of documentaries on Netflix about end of life care and facing death. So we are moving in the right direction. Go ahead, Shelley.
Yeah, regarding the question about just having the conversation with the group of the family or the patient, not them all together. That happens a lot for me. Sometimes the patient just wants to watch how I interact with the family to see how they feel about having other conversations with me. So sometimes that first visit is rapport and trust building. And then even once the visits are continued and they turn into routine visits, the family many times doesn't want to upset the patient. So they don't want to broach this topic about your dying mom. They don't want to believe it, or they don't want to have the conversation because they know they're going to cry. And when they cry, they know mom's going to cry. So there's that. And then if I'm just talking with the patient alone, the same thing. The mom knows she's dying, but she's trying to put on the stiff upper lip, so to speak, to be strong for the family because she doesn't want them to cry or she doesn't want them to suffer more. So there's a lot of that going on. So my role then usually becomes the bridge in between to normalize and to help them find their words and help them, come to a place where it's okay to talk about these things together. And I might do that incrementally in a few visits. And when there's rapport and trust built, then that conversation opens up and it's a process, as we know. So that's what I wanted to share.
Yeah, absolutely. Thank you. And so you're a chaplain, I take it?
Yeah, I'm a chaplain in a hospice.
Okay, I think, let's see, someone else have their hand up? Nope, I guess not. Well, we lost Brian and we didn't get, and Kamal is not with us. So we've got a small little panel here. So you guys can jump in and we can just talk about anything you want. Whatever, what stood out to you in the conversation today? I teach a lot about toxic theology and religious trauma, and it's such a difficult subject for a lot of people. And so I usually start out by a disclaimer saying, some of the things that we might say here might be a little offensive to some of you. So I hope that we haven't offended you. And if we have, you feel free to say so. This is why we have to have these conversations. Okay, here's some hands. Taylor, I think you were next.
Supporting chaplain. I'm a social worker and I'm the psychosocial director at my hospice. And one of my employees who's on here is a chaplain. And how do I, as a non-chaplain, support her so that she can properly support our patients?
Could you repeat the last thing you said? You sort of faded out there.
How do I support her as a non-chaplain so she can appropriately serve our patients?
Support the social worker?
The chaplain. I am a social worker.
Oh, okay. I am not a social worker, so I don't know. Would anybody like to try to answer that question? How does this, I know how chaplains can support social workers, but I wouldn't know how to answer that in the opposite. Any of you social workers like to comment? I mean, we all support each other. And, I'm going to jump in here with something because we were talking about ritual earlier. Some of you may have heard me tell this story before, but I know of a chaplain in a hospital who did something so amazing. She was Native American. This was in Arizona. And in the doctor's locker room or coffee room or wherever, doctor's lounge, where they go and they put their clothes in a locker and they put on their white coat and go to work. She put a bowl of little stones and a bowl of water. And she put a little note on there telling the doctors what they were supposed to do with this. And they were to take a stone and put it in their pocket and carry it in their pocket with them during their shift all day long. And anytime they had extreme stress or extreme grief, or a traumatic case that came in and they were so emotional, but they couldn't do any sort of self-care or deal with it because they had to go immediately to the next case, they would take the stone and they squeeze it really hard. And they carry the stone in their pocket through their shift. At the end of their shift, they go back in the doctor's lounge, take off their white coat, take the stone out of the pocket and put it in the bowl of water. And every day when the chaplain came in, she took the bowl full of water and stones and she went outside and she poured the water into the ground at the foot of a tree and took all that anxiety and all that pain and all that grief and gave it to Mother Earth to hold that energy so that the doctors had released it from their body because trauma and stress lives in the body. And she did this little ceremony. Then she'd bless the stones and bring them back and put them in the doctor's lounge to be used again the next day. So I can attempt to answer your question to say that one way we can support each other is by the use of ritual and ceremony. Karen was talking about the thing where someone ties a knot in a string. And I do a similar thing like that too, when you're sitting with a dying person and you tell the story of their life while rolling a ribbon up into a little ball. So you're sitting with your mother and she's dying and you're saying, I remember when you taught me how to ride a bike and here was the time we did this and that. And you have this beautiful little rolled up ball of string and you put it in the coffin with her, or you put it in the cremation. Or if somebody's already died, you do a string like that for grief. I will send you a link to a demonstration of this. So, things to help, how you help anybody with stress or trauma is to get it out of the body, because trauma is physiological more than psychological, and holding it into the body is what makes us ill. And to me, that's like the immediate intervention for anything. Craig, do you have a thought about that?
No, I would agree with that. I mean, I think if, and I was sort of actually kind of following the chat thread. There were some fascinating comments in there, Terry, that you might want to go back and read, where people were talking about like the challenge of there's some teams that sound like they navigate this partnership between social workers and chaplains really well. And that involves supporting each other, but it also involves like having the chaplain step in when there's spiritual distress and the social worker maybe out of their lane a little bit. So again, the integration is there, but it takes the team approach. But then some folks were starting to chime in and talk about how they may be supervised by a medical professional that doesn't understand the social emotional care and some of the frustration around that. So it's really, that's really interesting to me to see where you've got supervisors who don't really understand.
Boy, that's a
classic
really
kind of
good-
thing, right?
Yeah.
So you got a supervisor who doesn't understand your job and they can't support you because of that. So there was just a beautiful thread going down through the chat there.
Well,
So.
You got, and you know what, Craig, whenever you see something like that, if I'm missing it, just jump in and interrupt me and bring it in. Let me get some people whose hands are up. Angela, go ahead.
Yeah, I'm unmuted. I think one of the things to remember is who are the people that are spending the most time with patients. And I'm a death midwife, and I've done professional caregiving before for end of life. And just observing the hospice staff and how they interact with the families and the patients. And I find that a lot of the times the aides are the ones that spend the most time with the family, and that we really need to be training the aides on things like dehydration and the process that is in natural dying and things like that. Because I think the family, you know, they have a lot of anxiety around when the patients, you know, stop eating and drinking, and they look to any hospice person for the answers. And I find that a lot of times some of the younger, you know, aides just really haven't been trained well enough to communicate.
That's a really good point. Yeah, and I suppose, you know, one solution is, you know, more communication. And it's hard, you know, with COVID, because at my hospice, I've only been there just over a year, and I've hardly spent any in-person time with any of the staff, you know, just the few chaplains that trained me, and we don't have in-person meetings. We don't go out to lunch together. We don't go to happy hour, you know, that whole close interaction thing doesn't really happen. And that's changed a lot, I imagine, for everybody since COVID. Someone else, I think Taylor, did you, or Jane, did you have your hand up?
Yeah, I've just been thinking, I'm in private practice as a social worker. My specialty is grief and loss. And I love the talk about the spiritual, but not religious. I think I would love to hear conversation about helping people who are spiritual, but not religious, right? Who've either not grown up with religion or who've left religious frameworks that don't work for them, about helping them find language for their spirituality. Because often I will have people come in who are grieving losses, and I will ask all the questions that we've talked about today. And, you know, like Craig said, you know, what is the role of this in your life? Is it important, that sort of thing? And often people will say, yes, I'm spiritual, but not religious. But I think that there is work for all of us to do to help some of those folks put language to what they actually believe or find comfort in. I often joke, I live in Portland, Oregon, and often if you ask somebody that question, they'll tell you what they're not, instead of tell you what actually is the foundation of their resources or in their spiritual life.
Well, I think we talked about this earlier. You know, there is no, finding language is the trick. That's the thing. And there is no answer. Sometimes it really is. Here's what I don't know what I am, but I know what I'm not. You know I don't believe that I'm going to hell to burn an eternity forever because I had an abortion. or something, you know? So why do we have to really know? I mean, does anybody really know how to define their spirituality? One of my favorite professors in seminary said something that's my favorite quote forever and ever. And it's, when talking about theology, nobody knows what they're talking about. So do we really, you know, need to be able to define it? And one of the great things that I've learned in my work is how to say, I don't know. And I was giving a talk someplace once and somebody said to me, so what do you believe in? And I thought, I have no idea. I really can't even answer that question. I, know that there's a non-physical universe, not just the physical one. I know there are other dimensions that consciousness can exist on. I know that consciousness continues after the body dies. That's pretty much all I know. Maybe it's not as complicated as we think it is.
But you just gave me that right there might inform how you grieve. What you just said, those two things.
Mm-hmm.
So I was just wondering if anybody has any comments or experience around, working with somebody whose spouse has died on the table in a routine procedure, right? And it's 6 months out, and exactly those questions are things that they have not given much thought to. And now it's really about a relationship with somebody who's passed on, that sort of thing. That's what I was just wondering.
And, as I said in my talk about Fowler, that people don't think about that until they have that loss. And 6 months isn't a long enough time to formulate a new theology. Like Brian said, it takes years and years. So somebody dies, an unexpected tragic death, a child, and 6 months later, you're not going to be able to articulate your spiritual views. It might take you 20 years to land on something that you can articulate. I will tell you though, from the research, Drescher did a lot of research on SBNR populations, and one of her statements is that, she interviewed thousands of people, that they showed fewer attachment to doctrines related to divine reward and punishment, and that they generally did not infuse their experience of loss and grief with doctrine and dogma.
Mm-hmm.
So it could just be that simple, like I'm grieving, but I'm not attaching any religious narrative to it. But I don't even know that most grieving people would even be able to verbalize that.
One thing that I found helpful in hospice was Paul Tillich said that a person's spirituality is their ultimate concern in life. That's how he would define it. And so that phrase, ultimate concern, became helpful to me to not even necessarily ask the patient, what's your ultimate concern, but to listen to them and to hear in what they talked about and what they told me was their ultimate concern. And I remember one patient who refused the chaplain, didn't want to talk at all about forgiveness or anything about relationships, nothing that appeared spiritual. So in our team meeting, we were saying, but what's his ultimate concern? And we realized he loves baseball. Baseball is the only thing he cares about. He talks about it constantly. He knows all his stats for all the teams, and he has his favorite players, and he has pennants and banners. And so I said, that's his ultimate concern. That's what we will talk to him about. So every time we'd visit, we'd talk about baseball and we'd listen to his stories. And finally, one day he said, my biggest regret in life is that I became estranged from my ex-wife and my son a long time ago when he was little, and I never took him to a baseball game.
Aww.
And it was like, wow, we had this breakthrough. We understood through his ultimate concern of baseball, we finally found out what is his pain that was unhealed in his heart. And so we had no idea it would end up that way, but he ended up telling us exactly what he needed and what he needed to focus on.
And it's so great when you have time to work with somebody like that over a period of weeks and weeks. And sometimes if you're a chaplain in a hospital, you meet with somebody one time. And you don't have time to go that deep. So that's an amazing story. I want to address these questions about abortion and stillborn child. Richard, I assume you're saying that the stillborn child, the question came up, the person felt like they were being punished for having had an abortion. I have a client dealing with that as well. Her child died of leukemia at 9 years old, and her toxic spirituality around that is she believes that was God punishing her for having an abortion 20 years earlier. That God took the 9-year-old in exchange for the one she aborted. Is that what you're referring to there?
No, it was just more the young lady going through it. She was very young, and it had nothing to do with a previous abortion or anything like that, or even toxic theology. It had more to deal with. I had to talk to her about the fact that a lot of what she was feeling, because it had just happened like a week before, that she really should talk to her doctor, to her primary care physician, because some of the things she was going through were grief, and some of them may actually be physically related because of the fact that she's lost a child and there's so much going on in her physical body that she needed to talk to her doctor about it as well, and not just assume that it was all just the grief.
Right. And isn't that a protocol for us? You know, when somebody comes to us with a emotional problem, that we first have to rule out the possible physiological causes.
Exactly.
Yeah. Yeah. There's a wonderful book that I'm going to recommend here. I'm going to type it in. It's called The Smell of Rain on Dust by Martine Prichtel. It's a small little book. Martine is, he's an American white guy who grew up in New Mexico, adjacent to many Indian reservations, and ended up living in South America and getting initiated as a shaman into a tribe. He's now probably 70 years old. And it is, oops, I sent it to the wrong person. This is, in my opinion, the #1 best book on grief ever written, bar none. And it's nothing like what you read in your typical pop psychology, pop spirituality books. He talks about grief as praise. If you don't praise what you lost, you can't grieve. If you don't praise what you love, you can't grieve what you lost. There's all these just beautiful things. And he's the one that taught me doing that string winding up ceremony. So if I'm going to leave you today with one book recommendation, it's not going to be any of mine. It's going to be his. And I'm also going to email all of you with links to Karen's books and Brian's work and everybody else. So you'll have all of that. And we have like 2 more minutes. Anybody else want to throw anything in here?
The question about working with narcissistic patients or family, I would say to that, anytime anyone has characteristics of a personality disorder, they're sort of inherently difficult to work with. And the one thing I would say is there's nothing in the fact that we're service providers that says we can't set limits where we need to do so to protect ourselves physically or psychologically. And so we sometimes get caught in this caretaker role and think we have to accept psychological abuse from people, and we don't. We can professionally, compassionately set boundaries. But the other thing I would say is there is a theory, and I hold to this theory, that people who have been diagnosed with personality disorders almost always have significant trauma history, and that the personality disorder is really an acting out of that. And I share that because they're still often very difficult people to work with. But if you can hold the fact that this is probably a manifestation of their wound, it may be easier to hold compassion for them. Mm-hmm. And that's really important, because that's not typically what they get from other people, because their interpersonal style is so off-putting. So part of what I always try to train students to do is figure out what most people in the world give this person, and make sure you give them something different. So if they tend to irritate people, just take a breath and be patient with them as best you can.
Such a good answer. Such a good question. Yeah. Well, we could just do this forever and ever and keep going because it's so good, but I think we're going to have to stop. I am going to ask those of you who want CE credit to stay with us for a minute. Don't go away yet because we need to check you out. And Angie, can you do Brian's list? We'll keep them here for a few more minutes. Thank you all so much. This is our second year doing this particular symposium. This is our mid-year conference. We have a big conference every year in July. And so the new system is this is the little mini conference for January. And the conference coming up in July is live in Portland. I live in Portland also, Jane, in Lake Oswego. So we're neighbors. Hi. And Craig, I would love to have you come to that conference as well, but I don't know that we have an open spot right now. So I'm going to work on getting you in there because I love your topic so much. And that is the conference on death, grief, and belief. I'm taking a big risk with this because I'm kind of coming out and, speaking loudly about or against, I should say, religious trauma and toxic theology. That's another thing. Craig, I don't know if you're familiar with Marlene Winnell, but she coined this term religious trauma syndrome for children who were raised in cults and strict religious settings. And the hope is that will become a syndrome, that will become a diagnosis. What do you think about that?
I'm not the best person to ask about diagnoses because I think it's all trauma. So I think the DSM is built on manifestations of trauma, which I don't care for because we say that trauma is a normal response to what has happened to you, but then we pathologize it by labeling it a disorder. So there's this inconsistency that drives me absolutely nuts. So I think we take people who already have an overdeveloped inner critic, they're super hard on themselves, and then we start labeling them with these really, we pathologize these normal responses to life circumstances. If somebody grows up in a cult, of course, they're going to have trouble regulating emotionally, and they might be anxious, but again, it's a normal response to what happened to them. So I'm a bit of a rebel when it comes to the DSM. I can speak the language, and I diagnose for insurance purposes, but it's just not how I think about people in the world.
I think I agree with you. And so you must not be really happy about the bereavement exception that they added.
I just heard about it and I haven't looked at the details of it yet, so I can't speak to it. So.
Wow. Well, thank you so much for being with us. Karen, thank you. It's always so good to see you. Thank you, Brian, who has left. He's not here anymore. And if the CE people will just bear with us for about another 3 minutes and stay on, all the rest of you can feel free to go. And I thank you and bless you all so much. And you will all get an email sometime tonight or tomorrow morning. So thank you, thank you, thank you.
Thank you, Terri. Thanks, everyone.
All right, everybody. Bye.
Bye.
Okay, we're just going to sit and do our CE thing here for a minute.
Recording. Is that okay?
What's that?
Stop the
you
recording.
can. Yeah, stop the recording. Thank you.